Are we good? All right. Good morning, everyone. Good morning. If you'll find your seat, please. We're going to go ahead and get started. All right. Well, happy Wednesday morning to everyone. It's so delightful to have a room full of outstanding professionals within our network, folks who are here to be a part of a very timely and critical conversation. So I extend to you the warmest welcome and want to thank you for the effort you've made to be here today. For those of you who I don't know, my name is Lance Robertson. I'm the Assistant Secretary for Aging and the Administrator for the Administration for Community Living at the Department of Health and Human Services. Like you, I am so excited that today is finally here. But I know that we'll have more of an opportunity to share some enthusiasm around today's topics here in a few minutes and deeper into the program as the day goes by. What a great turnout. We had a limited number of seats and we were very purposeful in who we invited. And I know some of our colleagues, unfortunately, were unable to be with us because of the COVID-19 related travel restrictions. But as I look out, I can see a room full of people with tremendous expertise. So we are glad that today is here and it's going to be an exciting day. I want to go ahead and jump to our first speaker. It's delightful to have Mr. Jim Parker here with us. Jim has graciously agreed to step in on behalf of HHS Secretary Azar, who we all know is very busy on some pressing matters of national importance, since he is leading out on behalf of the department when we're talking about the federal government's response to COVID-19. Jim's official title is Senior Advisor to the Secretary for Health Reform, a title that is extremely fitting in many ways for what we are here to do today. Jim has been in that role since May of 2018, and he works closely with Secretary Azar to guide the development and implementation of health policies that will improve America's health system. Jim has over 30 years of executive-level experience in healthcare and healthcare policy. He has spent much of his professional career with Anthem, where he held a number of senior executive and leadership roles. And we have some Anthem colleagues in the room today, so I know they know Jim, and many of you in the health sector space probably know Jim. Immediately prior to joining HHS, Jim led the turnaround of MD Wise, an Indiana-based Medicaid managed care organization, and he served as president of Indiana University Health Plans, an affiliate of Indianapolis-based IU Health, a top 20 health system. So again, with that, we're so delighted to have Jim here. Please join me in giving Jim a round of applause. Thank you, Mr. Parker.
Thank you. Good morning, everyone. Thank you for being here today. As Lance mentioned, Secretary Azar was very much looking forward to being with you all this morning. As I'm sure you can imagine, the situation with COVID-19 is demanding a majority of his time and attention today. He sends you his greetings and wanted me to convey his deep appreciation to the leadership of the Administration for Community Living for putting together this national summit, as well as his gratitude for all of the healthcare organizations you've chosen to be here today. Today's conference is just another sign of one of the most encouraging trends in healthcare today, the growing recognition that we can deliver better health, lower costs, and better value in our system by better cooperation between healthcare and human service providers. Everyone representing a healthcare payer is here because you're interested in that kind of work, and I want to assure you that we are equally interested at HHS. President Trump, Secretary Azar, and our HHS leaders believe that addressing non-health factors that affect health, often known as social determinants of health, can be a key, impactable way to deliver better health and lower costs. Now, that may not be so obvious when you take a look at the overall budget ledger at HHS. HHS spends over $1 trillion a year on health care for Americans with complex conditions through Medicare and Medicaid, which far outstrips any other investments the federal government makes in America's well-being. There are a variety of reasons why the federal government takes the lead on financing health care, and that is not about to change. but we believe we could be spending somewhat less on health care, and most important, support better health for the Americans we serve if we did a better job of integrating health spending with addressing non-medical needs. Increasingly, more private sector payers for healthcare services are recognizing that too. One of the challenges in doing so is that while we have large integrated systems for healthcare payment and delivery, our system for delivering social services is highly decentralized and varies across states and communities. The services and supports that make it possible for older adults and people with disabilities to live in the community are provided by state and local governments, churches, and other local organizations, as well as the community-based organizations that form the aging and disability networks supported by the Administration for Community Living. I want to encourage all of the payers here to consider that these providers can be important partners in your efforts to address non-medical needs to lower costs. And by working together, we can refine and replicate partnership models that capitalize on the strengths and overcome the paperwork challenges of the decentralized social services infrastructure. Ultimately, the reason that we need to look at non-health needs is that expensive health conditions can arise in all kinds of ways. Each patient is different, their needs are different, and they deserve a health system that recognizes that treats them, like Secretary Azar likes to say, as a human being, not just a number. As many of you know, HHS has already begun to pioneer models for how to address social determinants in a community-based way. In 2017, CMS's Innovation Center launched the Accountable Health Communities model, in which participating providers screen high utilizers of healthcare services for social risk factors such as food insecurity, domestic violence risk, and transportation, housing, and utility needs. Patients with identified risks are set up with navigators who can help determine what community resources are available to meet the patient's needs. The first evaluation of savings from this model will be released later this year, but we already know that we're identifying and meeting needs with existing community resources. Through January of this year, participating providers have offered nearly 1 million screenings to Medicare and Medicaid beneficiaries, identifying about 170,000 beneficiaries with at least one health-related social need. Thanks to being guided through social service options, about 50,000 beneficiaries reported that over 21,000 of their health-related social needs have been resolved. I want to emphasize what's unique about this approach. One approach to social determinants of health might be to say that we should identify a couple of the most common needs, like nutrition or housing, and really focus on investing in those. But that's not going to be of great use to someone in, say, a rural area where food and housing may be affordable, but finding a ride to their healthcare provider is the real challenge. Secretary Azar likes to say we don't believe in a rifle shot approach to human services. You can't focus on one or two needs to the exclusion of others. Just like how every healthcare patient presents differently, every person has unique social service needs, and we are intent on designing models that connect them to the services they need rather than offering a one-size-fits-all approach. The Accountable Health Communities model recognizes that, and it also recognizes that working with community-based organizations can be one of the best ways to find providers that are already working to meet the needs of people in the community. In fact, one of the model's participating organizations, the Denver Regional Council of Governments, is the ACL-supported Area Agency on Aging, or AAA, for that region. As the Denver AAA, the Council operates a network of community service providers that already works to address more than 35 social needs, such as transportation and food security. The Council is one of more than 20,000 community-based organizations in the Aging and Disability Network supported by ACL. They've already gotten to know the needs of the community, and some of them can offer unique services that community-based organizations are best at providing. they can be a near turnkey solution for healthcare organizations looking to address social determinants of health. I'll give you an example from the Medicare Shared Savings Program in Alabama. Area agencies on aging across 15 rural counties in the state worked with an ACO there to better understand why their patients with congestive heart failure kept coming back to the hospital. Just pursuing better clinical care coordination didn't show results. But when they started to screen for depression and other social needs and connect people to the services to meet those needs, they saw a significant reduction in readmissions. We have seen similar results through similar partnerships in Medicare Advantage and state Medicaid programs too. A key reason these partnerships are successful in reducing costs and improving patient outcomes is the specific approach they take to address non-medical needs. They start with working with the patient to get a true understanding of them as an individual, their lives, what's most important to them, and what they need to thrive. That person-centered approach is a hallmark of ACL's Aging and Disabilities Network, and expertise in patient-centered planning is a critical asset that healthcare can leverage through these partnerships. The Aging and Disability Networks are an existing, trusted community resource with extensive research into patients' homes. Let me give you an illustration of the value that can bring to a partnership. VAAA Cares is a network of community-based organizations in Virginia that is contracted with healthcare payers, including several of you here today, to provide care transition support, chronic disease self-management services, mental health screenings and intervention, and many other services. VAAA Cares has a reach into the homes of over 1,000 Medicare beneficiaries each month. They know if these people are hungry, if they need help getting to the doctor, or how they can make changes to their home to prevent a fall. With that information, they have connected people to services when they need them before they develop into crisis, and they've seen impressive results. Hospital readmission rates have dropped from 23% to 9%, creating a significant savings for their healthcare partners and for Medicare. We see similar benefits for Medicaid. For instance, Aging and In-Home Services of Northeast Indiana has partnered with payers to help frail older adults who would otherwise be in a nursing home to continue living at home where they want to be for an average of 3 years longer than others with similar conditions. They've also improved hospitalization rates, which means we're looking at a significant cost reduction for the state and to both Medicaid and Medicare. Now, we understand that there can be barriers to close partnership between healthcare and community-based organizations, including separate systems for referrals and disparate IT infrastructure. The healthcare and social services sectors essentially develop their IT independent of each other, without consistent technical standards to enable interoperability. This creates duplicative workflows and sometimes impedes obvious opportunities to provide better support to the people served by each system. ACL and CMS have identified this as a systemic challenge that we need to address, and today ACL is announcing a new prize competition to develop some solutions. They will be awarding a total of $500,000 in prizes to challenge stakeholders, like we have here today, to work together with health IT developers and others to create interoperable referral and analytics solutions. The department is also exploring other ways we can address these challenges. HHS's Office of the National Coordinator for Health IT is looking at how social needs can be better integrated into EHRs, and CMS is working to develop more standardized ways to record and measure non-health needs. These kinds of infrastructure challenges are often invisible to patients, but addressing them can help deliver the kind of healthcare system that President Trump has envisioned. An affordable, personalized, patient-centered system that puts you in control and treats you like a human being, not a number. President Trump and Secretary Azar are taking bold action to deliver that kind of system, and we encourage private payers to join us in this work. Ultimately, We're moving toward a system where you're treated like a human being, not a number, because your healthcare payer and provider are held accountable for your health and your outcomes instead of the volume of procedures they provide. Such a system will present exciting opportunities for everyone in this room, so we look forward to working with all of you to make it a reality. Thank you for your dedication to this cause, and thank you again for being here today.
Thank you so much, Jim. I know we all appreciated those remarks and your words of encouragement as we kick off today's summit. I want to move now to some introductory remarks and some welcoming remarks by a good friend of ours from CMS. It's my pleasure to introduce Demetrius Kouzoukas, the Principal Deputy Administrator of the Centers for Medicare and Medicaid Services and the Director of the Center for Medicare. Demetrius leads the staff that develops policies for and manages the operations of the fee-for-service portion of the Medicare program. He also has responsibility for Medicare Advantage and Medicare prescription drug programs. From 2003 to 2009, Demetrius served in a number of senior roles at HHS, including Principal Associate Deputy Secretary and Deputy General Counsel. He has responsibility for regulatory policy across the department and at various times collaborated with and advised every division at HHS during that tenure. Demetrius has also worked with a broad spectrum of healthcare stakeholders in private practice as a lawyer, providing strategic advice on legal, regulatory, and public policy matters. In addition, he has been a senior executive at the nation's largest Medicare health plan, where he led a team of legal and regulatory affairs professionals as general counsel. Originally from Chicago, Demetrius earned his degrees at George Washington University in political science and public policy and the University of Illinois, where he earned his JD. So with that, please join me in welcoming Demetrius to the podium.
Thank you, Lance. I am reminded that someone told me that in Washington, the longer the title, the less important the job. The best ones are one word: president, secretary, administrator, so on. But it's been really a great honor to work in so many capacities, including with Lance and Jim, and I see Josefina in the audience. It's great to see her. Really good to be here with you today, with this particular crowd. I'm honored to talk to you on behalf of CMS and the administrator and share, in particular, the administration's vision for the Medicare program. I want to drill down a little bit to the kinds of things that Jim talked about and what they mean for the Medicare program in particular. And I want to describe in detail the steps that this administration has taken to modernize the program, in particular to put patients in the driver's seat. So in my current role at CMS, I have two particular privileges or roles. One is to support the administrator in her leadership of the agency with a focus on Medicare and the many changes we're making to the program. The second is to lead a very talented and hardworking staff that develops policies and manages the operations of the program. It's a humbling role. Medicare processes 1.2 billion claims, worth $750 billion on behalf of 62 million beneficiaries each year. Medicare's immense size has made it the benchmark for the rest of healthcare. But beneficiaries also get care from their communities, and that's where you all come in. Medicare doesn't cover everything, and community-based organizations and institutions such as churches, civic centers, schools, non-governmental organizations, and so on play an integral role in offering more personalized and tailored care than Medicare's immense size could ever allow for the things it does cover. Now, please raise your hand. How many of you have a family member or a loved one who's a Medicare beneficiary? I love doing that because it just shows how the work of the Medicare program, everywhere I go, when I ask that question, literally everyone in the room raises their hand. And it really demonstrates the intense impact of the Medicare program on everyone's lives, even if you're not in the program. Someone you love, someone you care about, someone you work with, someone you know is very much involved and engaged in the Medicare program and affected by it. So I'll ask you to think about the health care that loved one gets. I bet many of you, if not all, particularly given your profession, have fielded questions about Medicare from someone who's confused. They're trying to resolve some issue related to Medicare. Why is it this way and that way? The doctor says this, the billing office says that, the hospital says something different. It's all very confusing, and it's really a reflection of the fact that the program has really grown up in silos over time, and we're working hard every day to resolve that. I'll ask you to consider further, in those situations where your loved one was confused or asking you a question, did they feel like they were in charge, like they were empowered to drive their care? Those are the words we use all the time about where we want people to be. But you know from your own experience that we're not there. We're far from there. All too often, when I ask the question, the answer I get is, are you kidding me? So for me, it's personal. My father dealt with chronic disease as far back as I can remember. And the Medicare program was really like another member of the family. We all had to figure it out. Mom, dad, kids, cousins, whatever it took to get it right. And so now in carrying out the responsibility of running Medicare, my mind always goes back to the times when my family encountered a healthcare system that was infinitely complicated and all too often seemed to array everything against the patient, stacking the deck. Looking at this experience, it seems clear that in a time of personal health crisis, when everything is on the line for patients and their families, when everything that matters to them could go one way or the other, their options for what care to get and how to get it are determined too much by Washington. And now I'm part of that problem too. But it doesn't have to be that way. We don't have to accept what we call stacked deck. For those of you who've been following the Medicare program, you have perhaps noticed a steady stream of changes we've been making. I'm often asked what we're trying to accomplish through these changes. They're manyfold. They go at the problems in the system in many different ways. And what is the common theme? To be clear, everything we have done in this administration related to Medicare, under the leadership of the administrator, the secretary, and the president, is designed to ensure consumers are empowered. Everything we are doing is designed to make sure that every stakeholder in healthcare, every company, every entity, every hospital, provider of any sort, for-profit, non-profit, big or small, whoever and everyone, is competing fiercely, wrestling or racing or just excelling for the loyalty and choice of the patient or the consumer. I want to work through a few examples so you know these aren't just words. The examples of things we've done to date to give you a clear picture of what the changes mean for patients and their families. The first example relates to a situation many of you in the audience might be in. So many of us had the good fortune to be loved and cared for by our parents as children. As mom and dad age, you find that they start to require more care and attention. And all of a sudden, you're in the sandwich generation. And you wonder how they manage to do it for you. You know they need help. You're happy to help. But you find that sometimes they need more assistance than you're able to provide. You're falling further behind in life. If only you could just get an afternoon to catch up on other responsibilities, you could make sure they get the daily care they need to stay at home or avoid a hospitalization. Your parent has Medicare, but the rules of Medicare says the Medicare would pay for the hospitalization, but not what your parent needs, specific to the situation to help them. You don't have time to figure out other options. Here again, the deck is stacked against people. We changed that. Medicare Advantage plans are now able to offer respite care to beneficiaries and their caregivers. This means that the plan can send a caregiver at no extra taxpayer cost to lighten your burden and allow you to tend to other responsibilities, while ensuring mom and dad still have access to the care they need. And all at the same cost as the Medicare benefit from before. We've accomplished this principally through changing the flexibilities that the federal regulations have previously limited. Example 2, in your prime, you were an active member of your community. You attended city council meetings, you were in church every Sunday, you volunteered at the local hospital. But last year you had to give up the car keys. Now you depend on others to get around. And unfortunately, you're not able to find rides all of the times that you need them. You miss your friends, you feel guilty that you're no longer able to usher at church on Sunday mornings, you begin to resign yourself to the boredom that has set in over your life. You can imagine many of us know folks who are just in this very situation. The most recent national poll on healthy aging finds that 1 in 3 seniors in the U.S. are lonely. I suspect the number's low, or actually higher than that the poll numbers know. Loneliness has been tied to adverse health outcomes, including heart attacks, strokes, depression, anxiety, premature death. We recognize that transportation can sometimes provide an insurmountable hurdle for our beneficiaries to maintain the lifestyle they're accustomed to, and the loss of independence can lead to tragic consequences, health consequences. So we changed our rules to allow plans to offer transportation to beneficiaries to engage in the activities like the ones I described, provided that this provision would be expected to help the beneficiary manage a chronic condition. And we didn't just stop at transportation. Thanks to the changes made by this administration, plans are able to offer beneficiaries with chronic conditions the help they truly need: home modifications, meal delivery, environmental controls, and so much more. Plans know what their patients require in order to stay healthy and well, and what patients feel they really need when they shop for plans. These changes put patients in the driver's seat by allowing them to have more options and benefits for more services at no extra taxpayer cost, allowing them to find a plan that truly fits their needs. Third example, consider a beneficiary who 10 years ago was very active, but is now homebound due to aging and disease, like the one I just described. The transportation benefits Medicare Advantage plans can offer will no longer work for this beneficiary. They can't even really get out of the house as much as they can, even with a ride. However, innovators have found a miraculous method to reinvent the house call for the 21st century. Telehealth offers a great solution to ensure that beneficiaries have access to the care they need to stay healthy. Patients in the private sector with insurance there can pull out their phones, open an app, and be FaceTiming with a doctor in about 5 minutes. I did it for the first time last year. It was really remarkable. But for Medicare patients, the deck was stacked against them. We are changing that. With the help of the last Congress, Medicare Advantage plans are now able to provide these services as part of their basic benefits, helping beneficiaries to utilize these tools more easily than ever before. Previously, plans had essentially been penalized for offering these kinds of benefits for the same price as would be paid under fee-for-service Medicare. We were even able to find ways to read the esoteric Medicare rules to allow changes for fee-for-service patients, those who are not in Medicare Advantage, to do something similar. So Medicare fee-for-service now pays separately for virtual check-ins, meaning patients can connect with their doctors by phone or video chat. In addition, Medicare will now pay separately for doctors to review an image texted to them by a patient. Because when patients are in charge, patient-driven care can mean no need to drive anywhere, just staying home and making the care literally drive to you. I hope these examples give you a good overview of what we are doing to empower patients by putting them in the driver's seat, and there are only a few. How we're focused on tangible results for people who've had the deck stacked against them for too long. Speaking of results, it's already obvious that competition is working. On average, Medicare Advantage premiums in 2020 are expected to decline by 23% from 2018 and 27.9% from 2017, and will be the lowest in the last 13 years. Average Part D basic premiums have decreased by 13.5%. You don't hear that too often, lowering prices, decreasing premiums. Taxpayers are saving nearly $6 billion in the form of lower Medicare premium subsidies. Beneficiaries have more plan choices for 2020, with about 1,200 more Medicare Advantage plans nationwide operating in 2020 than in 2018. MA enrollment in 2020 is projected to increase to an all-time high of 24.4 million beneficiaries out of approximately 60 million people currently enrolled in Medicare. This represents a 30.6% increase since 2017, and that's just the beneficiaries who have both A and B. So this is a very, very exciting time. We have lower prices for patients, more choices, additional benefits, lower taxpayer costs, and growing patient satisfaction engagement. The results speak for themselves. And the congratulations and the credit doesn't go to me or the government or really anyone else, but ultimately to the patients who are exercising choice and competition. While our reforms are helping to transform Medicare into a more patient-driven experience, we will still need partners to achieve the flexibility required for a 21st century healthcare system. This is where the work ACL is doing is so critical, financing and coordinating with community-based organizations. These organizations are on the front lines of providing for and working with beneficiaries, and plans are finding it useful to partner with these organizations to care for beneficiaries as opposed to investing in their own systems or having the government do it. These efforts are proof that the future of healthcare and elder care lies not in the federal government accruing more power, more heft, more responsibility, but in the institutions which bind communities, schools, churches, sports teams, families, and so on. Administrator Verma has said, the solution to our problems is right in front of us. It's all of us coming together, not relying on the government, to transform our healthcare system to make it more sustainable for today and for future generations. In fact, the answer to our healthcare finance and policy changes is staring us in the face, as the administrator said. When we go home from this conference, think of the loved ones you thought of when you raised your hand earlier. Those Medicare beneficiaries are driving change. As long as we empower them to transform the healthcare system from the bottom up through greater choice and competition, I have no doubt they'll do so. Thank you for being part of that transformative effort.
Thank you. I'm going to dismiss. All right. Thanks so much, Demetrius. And again, I know we're all grateful for his explanation of the CMS models that are proving to be true catalysts for the integration of healthcare and social services. So really grateful for your remarks, Demetrius, thank you. And it was wonderful to hear from Jim Parker on behalf of Secretary Azar. His presence here tells you that the Department of Health and Human Services believes very much in value-based healthcare, and the integration of healthcare and social services remains a very high priority. So one more round of applause as we dismiss both of these gentlemen. Thanks so much for Jim and Demetrius being here today. Thank you, Jim. Thanks, Demetrius. Appreciate it. You too. Thanks. All right. Both these gentlemen need to get back to the Humphrey Building, and again, we're so glad to have them here. I want to also remind all of you, I think you're all aware, that we are also live streaming this event. So in addition to the roughly 150, 160 prime slots we had for attendance here today in this beautiful, by the way, Kaiser Permanente facility, we also have folks, almost double the number, who are watching live stream. So I think that's exciting. Really excited about the rest of the day. So all of you have a packet that includes an agenda. And as you'll note, we have 20 plus presenters and panel participants that are going to be sharing a wealth of information and experience. For ACL, this summit underscores the fact that helping forge the integration of healthcare and social services is something that we see as vital for America. As participants, your candid contributions to discussions throughout the day will be invaluable. You will inform and influence a broader action agenda designed to benefit the many diverse stakeholders in the room. We also plan to stay engaged and to follow up with you after this meeting, because we see today as part of an ongoing effort. At the end of the day, you'll have an opportunity to let us know how you would like to stay engaged and what we can do to help keep this conversation going. Jim, you heard, mentioned a prize challenge for ACL, a challenge prize competition to be exact, $500,000, which for us is big money. Demetrius, who left, but for us, that's a lot of money. So it's an exciting opportunity for innovation that will help develop interoperable referral and analytics technology solutions that will help foster efficiencies for seamless integration across the health and social care sectors. We believe the outcome will be a demonstration of efficient data sharing that enables standardized referral processes. The result will also allow for follow-up protocols to track and support individuals when they obtain services from any organization or healthcare provider within the network. So I want to encourage everyone here who is connected to the Health IT platform conversation to please take a look at this new prize challenge competition, which can be found now. It's hot today on challenge.gov. So please go to the challenge.gov website for more information. I want to quickly do a couple of thank yous. First of all, starting with the ACL team. As all of you know, putting an event together like this takes a lot of time, a lot of energy. And I want to start off by thanking Kelly Cronin. For those of you that don't know Kelly, if you'll wave. Kelly has been our quarterback. She's our deputy administrator at ACL over the Center for Innovations and Partnerships. She has a team of folks who also helped. Joseph Lugo, Christy Kalinsky, Lauren Sokowski, also Christy Samuels, and so many others I would love to have the time to call out by name. But again, I'm so grateful for all the time and energy and hours that they put into this, and I think it's going to be a fabulous, fabulous day. So thanks to all of you. I'm also so pleased, amongst the many friends and colleagues that I have here, to also give a shout out to a couple of my predecessors who joined us today. So Kathy Greenlee, I know you're in the room. If you'll wave. Former Assistant Secretary for Aging. Kathy's now in Kansas, but a text or phone call away from me. And my good friend and also a predecessor, Miss Josefina Carbonell from Florida. If you would wave, Josefina. Likewise, we exchange messages pretty often. So thanks so much for both of you being here and the guidance you offer. I can see we have strong participation today from the healthcare sector, from the Aging and Disability Network, and from the state and federal government sectors, including both Medicare and Medicaid and HHS's Office of the National Coordinator for Health Information IT. I have a few other logistical notes that I need to share. Today's agenda includes 6 panel sessions, one of which will begin as soon as I finish these brief remarks. One panel session will happen at the tail end of lunch. And with the exception of that lunch session, we expect to have time for questions for the panel members. We're hoping to have a lot of participation today. So please be willing and able to answer or ask questions when you have them. We have provided some note paper and pens, and I know the moderators for each of those sessions are planning to invite your questions. We also wanted you to know that lunch is being provided today courtesy of SCAN, so we all owe Bruce a big round of applause when he comes to the stage. Amongst his expertise, he's also feeding our bellies. At 2 o'clock today, we will divide and conquer by splitting into 4 breakout sessions. You see it on your agenda. One is on financing social care. Another is on scaling networks of CBOs. The third is on technology enablers and barriers. And then finally, there is one that will address the role of federal and state governments. And again, that's at 2 o'clock. If anyone needs anything, we have a fabulous ACL team here of staff members who are ready to help. You'll notice on their name badge they have blue dots. So if you do need anything, please let us know and we'll get you to the right person. So this is an important day in the timeline of the integration of healthcare and social services. As you know, the shift to value-based healthcare is well underway. And I think we can all understand and appreciate the goal of value-based care, which Jim alluded to, which can be boiled down to 4 words: better outcomes, lower costs. We know that too often people leave hospitals, doctor offices, and rehab facilities having had their immediate healthcare needs addressed, but not the underlying social needs that cause them to need medical care in the first place. Too often, they end up right back where they started, in an emergency room or hospital. We all agree that we have to figure out a way to end this cycle. And the question is, how do we get there? What are the best, most realistic, and most cost-effective ways to address a patient's social determinants of health? We believe the answer lies in partnerships between healthcare organizations providing medical care and the network of community-based organizations providing social services that help patients maintain and even improve their overall health. And that's what today is all about. Discovering the path to shared investments that will reduce overall costs and have positive impacts for healthcare organizations and payers, our social service networks, and most importantly, the people that we serve. All levels of government have invested heavily in community-based organizations, and collectively we call them the Aging and Disability Network. Since 1965, this network has been a trusted source for delivering home and community-based services to 1 in 5 of America's seniors, as well as people of all ages with disabilities. This network includes more than 20,000 community-based organizations and is present in every community across the country. These organizations have unmatched expertise in local culture and needs. They excel in service coordination and delivery, and they know how to secure benefits, services, and supports that maximize independence and functioning of the people they serve. Their reach into the homes provides an opportunity to identify risks and connect people to interventions before health issues become a crisis. This network is the fabric of social services in America. And it's not only a safety net, it's a support system that is highly efficient and well managed. The Aging and Disability Network exists in every state and territory, and research has shown that healthcare providers who partner with social service hubs achieve better health outcomes for their patients at a lower cost. This is especially true for some patients with chronic and complex conditions. In this room and represented on the panels, we have people who are leading the way in building and scaling partnerships with healthcare systems and the Aging and Disability Network, and you're going to hear from many great folks. Jim pointed out the example with VAAA Cares, which is managed by Bay Aging. As one example, it includes partnerships with United Healthcare, Humana, Anthem, and several other states. That particular program is working well in Virginia and in neighboring states, but other models are in places and launching all across America in states like Alabama, California, Colorado, Florida, Indiana, Maryland, Massachusetts, New York, Ohio, Washington State, Wisconsin, and 27 other states. Isn't that exciting? So we have an opportunity now, my friends, to accelerate the integration of healthcare and social services nationwide through partnerships like the ones in the states I mentioned. This integration will need to involve shared financing and interoperable technologies at local, state, and regional levels. And of course, partnerships among equals have to include shared risk. No doubt, we will need buy-in from health plans and health systems, many in the room today, on the value of working with community-based organizations. We know that a single point of accountability is often highly desirable by healthcare partners, whether those partners are local hospital systems, state-level managed care organizations, or multi-state or national health plans and health systems. The community-based organizations know they will need to deliver services that improve health outcomes in a way that can be measured. And we know, thankfully, that's already happening. So as a result of today's summit, we will create an action agenda with steps each stakeholder can take to build, strengthen, and sustain an integrated system of social service and healthcare delivery that is a win-win. Again, today is not the beginning of the integration of healthcare and social services. As I said, that integration has already begun. But by the end of the day, I'm convinced that we will all see a more concrete path forward for a national integration that ensures every healthcare provider will see the value of partnering with America's Aging and Disability Network. So again, thanks so much for being here and helping us advance this goal. So I want to call up to the stage now Dr. Bruce Chernoff, and as he makes his way on this beautiful Wednesday morning, I wanted, just as a quick update, to share that for those of you that aren't tracking it, we're happy to say that the Old Americans Act has passed the Senate, and we're hoping that it gets through the House. We know the President's going to sign it, so that's a nice update. So that's one update. Another favor that I would ask all of you is to get to know one another. We've assembled a room full, thanks for being here, of some outstanding professionals across all sectors. So this is a prime opportunity during breaks and at lunch to get to know one another. So Dr. Chernoff is on his way. I think right here. There we go. All right. For those of you that don't know Bruce, he is the president and CEO of the SCAN Foundation. I recently had the great pleasure of working with Bruce on a blog for Health Affairs on the topic we're discussing today. I know a copy of that blog is in your packet, and it's an excellent read. So take a moment to read through that, please. Bruce has been at the forefront of this issue and has had a long and distinguished career that spans both clinical medicine and health policy. Before taking a leadership role at the SCAN Foundation, he served as a director and chief medical officer for the Los Angeles County Department of Health Services. Bruce has also served as a regional medical director for Medicaid and SCHIP programs at HealthNet, a network model HMO. He is a senior fellow at the Schaefer Center for Health Policy and Economics at the University of Southern California. And if you can catch him during break, be sure to ask him about his Japanese tea ceremonies because he is an expert on that topic. So with that, a round of applause for Dr. Bruce Chernoff, please. Thank you.
Thank you, my friend. Well, good morning, everybody. It's really a pleasure to be here. Great to see all of you today. I'm going to invite my colleagues up on the panel, and we're going to make sure we get us kind of back on time for your break. And we, as a panel, really want to leave plenty of time for your questions. I'm really pleased to introduce my panelists, who include Connie Benton-Wolf, who's the president of Aging and In-Home Services of Northeast Indiana, Tim Ferris, who is a general internist and serves at Massachusetts General Hospital, the Harvard program, and he is president and CEO of their physicians organization. And finally, Kevin Moore, who is the vice president of policy for United. I couldn't ask for a better panel, so if we could give a round of applause to all of them. And I'll recognize that their full bio is in your packet if you want more information. I guess I just want to make a couple of opening comments. We're here to set the table for a vision for the future. And I'm really struck by, I really appreciate Lance's introduction, appreciate the opportunity to write that blog with him, appreciated seeing leadership from HHS and CMS here talking about where we need to go. For me, that was a very table-setting group of comments to begin with. And, you know, for me, having spent 10 years as a practicing general internist, 10 years in kind of health management, in the last sort of dozen years or so in public policy, I'm really struck by the challenge of getting to the discussion we're having today and the importance of pushing to that vision in the future. The reality is, when you look at Medicare beneficiaries, let's just use them for a sec, picking up on where Demetrius was, if you bucket them into groups, okay, from people who have no chronic conditions, 1 chronic condition, 2 chronic conditions, 3, 4, 5, 6, you kind of get the idea. And then you break those buckets into 2 sub-buckets, folks who have 2 or more functional limitations and those who don't. So people without functional limitations and those who do. At every level of number of chronic conditions, whether it's 0 or 6, folks with functional limitations are twice as expensive to the Medicare program, twice as expensive to the Medicare program as those without. I'm talking about Medicare expenditures. I'm not talking about ACL expenditures. I'm not talking about Medicaid expenditures. I'm just talking about Medicare expenditures for a sec. So the point here is that function matters, and function drives spending. It drives spending in the Medicare program, and it drives spending in the Medicaid program as well, which is often a provider of services today that meet the needs of those with functional limitations. We need a better model. We need a future that responds to that. And I think when we look across the world, if you look at OECD countries, and you add up their medical spending and their social spending, we're about average. It's like a little known fact. We're about average. So what's really interesting is people love to point out, well, we spend a lot of money on healthcare in the United States and we don't get the outcomes that other developed countries do. And I think and people just say, well, it's about medical variation. And those of us who are physicians or who supervise physicians, if we could just get the doctors to be a little better about guideline practice or a little better about, our prescribing practices, that may be true. There may be variation in the way we deliver healthcare today that could be more efficient and effective. But the reality is there's this large gulf of spending that's going to meet unmet functional needs in ways that are very inefficient and not at all person-centered. They're barely even patient-centered. And so I think we have this wonderful challenge in front of us to change that narrative and do so quickly. I'll just remind all of us that when Medicare and Medicaid and the Older Americans Act were passed, the average life expectancy was, anybody know? Seeing who's awake. 62. Close. We have a 62. 67, getting closer, 69. So the Medicare program was built for you to live about 4 years. Life expectancy today is pushing 80, depending on what group you're in. And people are living much longer, but they're living with functional limitations. Roughly half of people over the age of 65 will actually have some level of functional limitation that could, quote unquote, make them Medicare eligible. And we're not going to put all those people, nursing home eligible. We're not going to put all those people in nursing homes, not by a long shot. This gets back to what do people want as opposed to treating folks like a number or just being a patient. So that's the challenge. That's how we need to build a vision that responds to that. These folks have some, I think, great insights. We're going to then work through the day, right, sort of going through the piece parts. Well, what does integration look like today? How can we, what guidance can we give ACL and CMS about some of the challenges in front of us? What can we do as we go back to our own organizations? So it's a real joy to be up here. I'm going to grab a seat, and we're going to start. So maybe for all of you, while I get comfortable, you could say something about, we tend to throw words around in the space, so maybe we could talk a little bit about what the word payer means in this context. Do I have a willing victim who'd like to start us off?
I'm guessing you're looking at me because I brought this up in the prep call. Hi, everybody. I'm Kevin Moore, and just so everybody understands, I work right now with United Healthcare Community and State, the Medicaid arm, but I'm a recovering Medicaid director, and I know that there's one person that used to work for me in the audience, so don't quote me on anything, Curtis. I think this is a really important question, though, about big P versus small p payer, and that even thinking through Medicare Advantage plans and or even a Medicaid managed care plan, we talk a lot about payers aligning, but also thinking about, are the payers aligning? Are we at a point where thinking about what Medicare Advantage is doing with supplemental benefits, what Medicaid is trying to do with specific populations, are they in alignment in particular with the member? And are they also in alignment as it relates to our community partners? Thinking about just a scenario that we've been bantering about as the opportunity around Medicare Advantage supplemental benefits. What does that mean if we're in a market or if we're in a state? I'll pick on North Carolina as an example because they've been doing a lot of work in SDoH for Medicaid. But what happens when you're a CBO and you have an opportunity with Medicare at a premium rate versus what might be paid through the Medicaid pilot? The money's you're going to make a business decision, not just based on your membership, but also based off of where the revenue comes. So how do we make sure that the big P payers are aligned so that us as smaller P payers are making sure that we're able to get the best bang for our buck? And again, coming as a Medicaid director, I come by, former Medicaid director, I come by this honestly, which is the Medicaid program is trying to innovate, but also are they willing to invest and reinvest the dollars that are being saved? Because If we're able to find food for somebody to keep them out of the emergency room, we need to make sure that that's sustainable over the long haul. And so what do we need to do? What are the policies that need to happen? Or maybe not even policies. How do you develop a glide path so that you can make the transition, like you said, so that we're able to start to slowly change where we're making our investments? And I think having all of the big P payers and little B payers all kind of driving in the same, not necessarily the same, but in alignment. Let's all pull the wagon at the same speed. That's going to be a huge benefit for our CBO partners so that they continue to stay at the table because they've got to be there.
Completely agree. Either of you, Tim or Connie, want to add to that?
I might just say that from the provider perspective, the lack of alignment, picking up on that word, is really very problematic. So in my organization, we have risk contracts with the state for Medicaid, with Medicare, and with all of our commercial payers. But all of those contracts are different, very different. The incentives are different. The rules of the game are different. And so when we build our programs, we don't generally try to build programs that are payer specific. That would be sort of a nightmare to manage. And so we try to build programs that average across all of those different contracts. And alignment, a little more alignment would be really nice from the provider perspective.
Connie, anything you want to add?
A few more payers would be really nice. One of the things that I'm Connie Benton-Wolf. I'm with Aging and Home Services of Northeast Indiana and co-founder of Preferred Community Health Partners and Ground Game Health. And the thing that, and I will say, I think I'm here because I'm the cheerleader for the Aging and Disability Network on this panel today. And I am proud to be here because I think the work that you guys have done has just been phenomenal. Assistant Secretary Robertson, I can't tell you how grateful I am for today. So let me just say that as we begin. This whole notion that we find a way to bring the payers in alignment so that, in fact, we're looking at the overall cost of care for an individual, to me, is what person-centered care is all about. I have known for years that the work that I do in the community under the social services label saves money over here on the healthcare side of things. But I've never been able to totally cross over and be considered part of that healthcare continuum. I think as we approach our payers, as we talk to our payers, and we make the business case for why this is important, we're going to start seeing that ambitious look at what is the overall cost for this individual and whether that savings is at the federal level, the state level, the local level with the healthcare system. If you can put those pieces together, we've got a really powerful package that's going to make a tremendous difference in this country.
That's wonderful. I mean, I guess I would say, as somebody who sits on both sides of the ledger, somebody who's a big fan, and the work of the foundation is deeply supportive of the Aging and Disability Network, but also somebody who's spent a fair bit of time actually on the plan side and on the delivery system side, I'd say alignment works in both directions, right? So, and the reality on the ground looks different in different places, so we have to be careful about assuming, and I appreciated the opening comments about not being a rifle shot, because those of us who've worked in or have had responsibility for large geographies understand that it just looks different in rural than in urban places. Service provision looks different. Skills and abilities are in different places at this point. So I see alignment as being a really key piece of this discussion. Connie, I want to keep the discussion going with you and having you talk with us a little bit about community integrated health networks. What do they look like at scale? I think for healthcare providers in the room, sometimes that can seem a little bit unclear because we have less experience with them. So set the table for us there, please.
I will say that I think that the Aging and Disability Network has made huge strides in the last 5 years. It has just been phenomenal to watch this whole movement kind of coalesce. As we start, I'm going to pull back, though, because part of what I think we want to talk about is the fact that the power of what we bring to the table is very much local and is very much in the home. I had my staff keeps me very honest. I have a little army of social workers that go out into the field every single day. I watch their cars go out, and I think about the good work that they're doing. I had one of them come back from a care transitions visit, and I was talking to her because it was a patient that we'd had a really hard time engaging with our usual routes of trying to set up an appointment with a phone call or a text or the usual things. So she just did a cold call. She walked in, did a cold call. And ended up coming back to me, and what she said to me, she says, Connie, if you can get me to the front porch, I can talk myself through that front door. And if I can talk myself through that front door, which I'm really good at doing, I've got a front row seat on this individual's life. And I can tell you in 20 minutes where their clinical care plan is likely to derail. And I sat back and thought about that, and I thought, you know what? That is the important piece of this. We get through the front door, we do have a front row seat, and by golly, you know what we're looking at? Social determinants of health. That's what we get to see from our front row seat. So if we pull back, we look at it locally, each one of my little army folks going out into the community every morning, and then you pull up, and you take a look at this from a broad perspective, what you see is the potential is there. It's huge. As Assistant Secretary Robertson said, we are everywhere. We're in every single county. We're in every community. By golly, we can get into pretty much every single home. That is so powerful. If I were a franchise, you'd want to buy me. You would want to buy me. And we could talk later, because who knows? But that's the important piece of this. And so what we've been doing as a network is we've been trying to figure out how we organize ourselves, because we know we're scattered, and we know we're not as sophisticated in a lot of ways as the managed care organizations or healthcare needs us to be. We bring a different kind of expertise to the table. And so I think what's important to know as we start our deliberations today is at the local level, we're out getting our contracts with local healthcare systems and wonderful partners. At the statewide level, we have marvelous examples of state networks that have developed across this country that are organizing within their states and able to take contracts that way. The other thing we're doing is on a national level, and that's the part I've been working with. We really believe to go to scale, we have to have a national infrastructure that allows the big organizations to do a single contract at an enterprise level and then turn on with scopes of work in the local community in a way that makes sense. And from you, Dr. Chernoff, one of the things that I learned is that there are three things that the payers are looking for: access standards, quality certification, and data. And I can tell you that the access standards are now built into our contracts, and we're used to working with them. When I have a deadline that says I have to see a patient within 48 hours, I see that patient within 48 hours. I've changed the culture of my organization to do that. Many of us have. Some haven't, but there are enough leaders now, early adopters in this network, to make it believe that that's happened. Quality certification, I know there are several. We happen to get NCQA at my agency, and we're watching that in my state of Indiana. Every single AAA is working on getting NCQA certified. On the national level, we built in all of the NCQA standards into the intervention that we're doing and the technology that we're doing, which leads us into the data piece. We've got to figure out, and I'm so excited about the prize that was announced, the prize challenge today, because that's another big barrier for us, or has been, and we've come a long way. We've been working on some different methods of doing this, but we have the capability, I think, to have an infrastructure with a data capability that will align all of the networks into a data system that gives us what we need in terms of the outcomes and has the cross-communication with the healthcare systems that we have to be successful.
Terrific, Connie. Tim, that leads me to sort of want to ask you kind of a flip side question. And one of the things I really respect about you, all of your work and your current role is we've all sat through enough panels where people want to talk about social determinants of health, and I always worry it feels a little bit like going to the tropical fish store, buying a 40-watt aquarium thermometer, sticking it in the Pacific, and praying the ocean gets warmer. And I think you have to get really realistic. It's fine in a population to have that level of discussion, But this is about meeting the needs of people and families and communities, right? Like, how do we build a future state delivery system? And it's a place where I know you've given a lot of thought and have a track record of work. And I was just wondering if you could speak a little bit to what does that future state look like? How do we get there?
Yeah. I haven't heard that analogy before, by the way, and I rather liked it. I might borrow it. It is a problem, though, that does feel like an ocean, right? And because the need is so pervasive, and for every need you find and address, there are others behind that as well. That shouldn't be. And I think in the past that has been taken as a reason not to get started, and we can't let that happen, right? And so, I just want to, so we've been doing this since the Accountable Care Organization started. I'm really pleased to see my fam in the back here, who I worked with as a colleague in creating some of those early accountable care organizations, and very early on in that process of asking healthcare to be accountable for health, it created the immediate realization that it's not just about what happens in the doctor's office and the hospital. It is so much about what happens afterwards, as you pointed out from Betsy Bradley's research. And so once you acknowledge that, then it gets down to the practical work of what do you actually do about it. So 10 years ago, or 12 years ago, I practiced in an inner city clinic where I was aware, often, not always, of the problems that my patients encountered. But even when I was aware of the barriers that they face in getting health care, even when I was aware, there was very little I could do about it. Every once in a while, I would make a whole series of phone calls. It would be a huge time sink for me, and it would be very difficult to navigate my way through the community-based organizations that I knew were out there, but I had no entry into. It was through the ACO program that we started to get organized about that, and the organization came in three specific ways. One was systematic screening. So IT allows us to do systematic screening. We screen all of our patients, although we are focused about it. Patients can get annoyed to be overly screened, but you have to select them based on risk and a few questions on their phone before they come in. And suddenly, now I'm seeing all of the answers to these social determinants of health screening questions before I see every patient as part of my medical record automatically. And it takes basically no incremental cost to collect the data once you've set up the system. That's really different from 10 years ago. The next thing that's really different is it's not me that has to do the work of figuring out how to solve those problems, because if one of my patients answers yes on one of those questions, in our system, I'm able to click a button. And one of the people in my office, actually a job that never existed in my office before, which is essentially like a social work triage. It's a sort of a new job description in the past few years. And that person does the work of figuring out what are the layers behind the reason why that patient answered the question about transportation barriers or medication cost barriers or whatever the barrier is. And then the third thing is we now have a database of all community-based organizations that address these things, and we are able to access that through our database. And so those three pieces, systematic screening, a specific role group that unburdens the clinician from having to do this work, and I don't say that in a way like it's not really a burden, it's just that I'm really busy taking care of my patients, and this is quite a bit of extra work that I need help with, a person on my team. They're doing that work. And then we have the data and infrastructure to actually make those connections to the community-based organizations. So I'll just say, as a clinician, the practice of medicine for me as an internal medicine primary care doctor has completely changed over the last decade, and it has dramatically incorporated the social determinants of health and the connections of community-based organizations that simply did not exist before the accountability for health came with the changing of the financial relationships with the payers. So So on the ground, for me, it's entirely different. It's really, really positive. But then maybe I should just want to add, related to your question is, so how do we relate to those community-based organizations? And that is a tricky thing to do. So when we relate to those community-based organizations, we have contractual relationships sometimes. Sometimes we just sort of make a phone call and do a handoff. But it's tricky. A lot of them are quite small. A lot of them are really under-resourced. A lot of them, frankly, my CFO says, well, hey, Tim, if they're the right thing, if we're paying them to deliver this service, we should pass on some fraction of the accountability, the risk that we take. And I look at those organizations and I say, ooh, a lot of them really are not set up to be taking risk. So how do we pass on accountability? How do we judge the best services? And that's actually a problem for us. You just gave me some great tips. Thank you. But I get the sense that this industry is in evolution and is responding to that pressure, the pressure that we are feeling and the pressure that we are now exerting on them.
Well, what we know is that exactly what you're saying, those were the barriers that we needed to address. And so we've been going about systematically addressing them. So yes, we do have solutions for you. We have solutions for Kevin. So Kevin and I really have to talk. But the way we've done it is realizing that, to corral 20,000 community-based organizations and make them function as they should, you really need a contractual level that allows you to make your referrals into that network and allows that layer at the network level, whether it's at the state network or us with our national network, take on that quality monitoring kind of responsibility, that training responsibility to make sure there's an intervention that meets the standards that you have, that's standardized, that can go then across the board, and then we can report back to you so that there's a feedback loop and you can adjust what you're doing based on what we're doing in the field. So that real-time communication is absolutely essential. So we are absolutely building that solution for you. And as you were talking about having that person within your staff, to do some of this work, it's a daunting task. But we're actually, one of the things that we're going to pilot this summer with a managed care organization, and we're going to start, I think, we're working right now in 17 states. With this new model, we're going to open it up this summer. And along with receiving referrals from managed care on the federal level into a system that then pushes those referrals down to the local provider and monitors what's happening to them, we're going to be able to take direct referrals for managed care docs. So the physician will actually be able to refer into our system. We can then take it down to the local area agency on aging, who then takes it into, or other community-based organization that takes it to the provider that provides it and loops it back to the physician. So those are the kinds of things that I think that are going to make this system actually work, not only for all of us, but for the people that we're serving.
So Kevin, I want to turn to you, and I have, having shared part of your professional experience, having spent 7 years in a plan on the Medicaid side and the CHIP side, I recognize what a really important role plans play here, because at the end of the day, a lot of what we're seeing is that the federal government and states is actually turning to plans to build the operating regulatory apparatus. And I actually think that that's a good thing, because the realities on the ground in different communities, even if we were just to pick one state that United's in, even within that state's geography, are different. And so I'm really interested, since we're talking about a future state, we're setting the table for a future state here, how you think about, to the comments we've heard from both of our colleagues, how you think about payment policies in particular, but policies in general that help drive the behaviors and goals we see articulated from both the provider side and the community-based side, right? Because not every organization's in the same place. I actually think the idea in the long run that there's an upside opportunity when community-based providers help improve outcomes, that's great. taking downside risk is a tricky thing for many of these organizations that are not prepared to do that today. Some might be, so I'm not trying to speak for everybody, but you are at the rub of that set of important discussions, and I wonder if you have guidance for us about the future state.
I would add one other behavior, which is probably the most important behavior, which is the actual individual. I think we can build out the best system from a managed care perspective, cross-payer, small p payer. We can build out ACOs that communicate with each other. We can build out networks that can talk to each other from a CBO perspective. But I think that if there's one thing that I'm excited about, we are one of the CMMI pilot programs in Hawaii. And I think that while we can articulate building an infrastructure, financing an infrastructure, we can talk about the number of screens, very important, the number of people who actually screen positive, even more important, the number of screens that they have, even more important. It's on this constant evolution. But I think it's really important to understand, so what? I have 4 or 5 or 6 different social barriers. I am chronically homeless. I have a navigator. I don't want your help. Go away. They have another infrastructure, though, that we have to make sure, and it's really about the CBO infrastructure, whether it be AAAs, whether it be, and let's be honest, it's probably that mom and pop shop that's been around for years, that is mission-driven, underfunded, financially insolvent probably if you looked at their books, who's the one that's sitting there saying, Kevin, let me help you navigate to the housing agency. I'm a food bank, but I know somebody that can help you out. I think the challenge in all of this from a health system down, government side down, is how are we taking the data, lessons learned, so that we're building a system and we're investing so that we're not only dealing with the ability to build out infrastructure, which again, is in my mind, is kind of a short-term investment. Not to say that it's one and done, but in terms of where the next play is, and we'll see this out of the CMMI grants a little bit, is once you make the referral, you got to pay for the services. And if we're trying to get maybe a little bit away from the few, which is the high-cost, high-need individuals, but we're trying to think of this as a population health / preventative measure, or even thinking about the comments about social isolation. And I raised my hand because my father was one who loves his doctor, not because he needs medical help, but because he talks to them, to the point of it was, oh my God, Ed's on the phone again. I can assure you that's an inappropriate use, but my father, even, again, guilty as charged, but there's a social isolation component there, which honestly, how do I get him out to breakfast with his buddies? Because that's what he needs. He doesn't need the doctor. But the question is again, how do you start to think of that upstream? How do you start to build infrastructure? How do you start to finance some of that stuff? My dad's a bad example on that side of it. But I think this is where Medicare and Medicaid duals, we need to start thinking about that intersection. Because as we build things up, I think we want to make sure that we're building them for the best of the overall infrastructure. And there's a phrase that was used by a friend of mine when thinking about this. If anybody, and I'm not going to belabor it, but if anybody hasn't done any research in what North Carolina is doing, and I pick on North Carolina, they've developed their resource and referral and screening tool. They've got a statewide screen, so they've come together. It's not everything, but it's a start. But they've developed a public utility concept. And I think the benefit of that is that it takes away a little bit of what are you doing, what am I doing, is my contract with you the right contract? But it also creates the ability for CBO to CBO to CBO interaction, which I think that's really where we need to harness that connectivity. And that's where I think from the health sector side, we need to listen. We need to understand the Rosetta Stone for translation because they don't talk about encounters. What's an encounter? And that's not that's not how they work. They work on a grant and then they go to 110% of the grant because that's what they're trying to do. AAAs are a really good example of that. They got more people in the door, figure it out. So how do we capture that type of element, not lose it? And the last thing in my mind is, how do we not get into the medicalization of social service delivery? I think it's important. We can code. We can do a lot of different efforts. But I think at the end of the day, the power of what makes this resilient industry and the sector so good is because it is different. It is local. And I think if we're going to be successful, to your point, we can't lose that. So a long answer to the question, but I think those are, in my mind, many of the few understanding long-term investment versus short-term investment. That's where we can get alignment from our side. But we need state partners and federal partners, as well as our CBOs, to all be in alignment.
I'd really like to open it up to questions at this point. We have a wonderful panel, and I think having you help us start to articulate that future vision is a great way for us to spend a little time this morning. So there are folks walking around with mics. Don't be shy. Please say who you are, and if you're from an organization, please share. That would be lovely.
Hi, I'm from Anthem. First of all, Tim, given your shout out, can I assume that all else that happened in the Pioneer model is now forgiven? But seriously, you had talked about a newly created role in your organization, and this may just be my naivete about the existing workforce, but it raised the question for me of whether any of you see any need for re-engineering of the related workforce that we need to address these issues, especially within the context of this ideal infrastructure that you've described.
Yeah. Well, maybe I'll take a start.
Great. Go right
stab at this, and I would say there are new roles in healthcare, but let me put it in a little bit of context. So healthcare itself is changing rather dramatically, especially on the ambulatory side. And what I would say is the digitization process that you've heard so much about, you've heard your doctor groan about, I groan about, was really just phase one of taking what was on paper into electronics. We are only just starting to take advantage of the digitization of healthcare information. And what that means is that all of the people who work on a team in the ambulatory setting, their jobs are being redefined. The doctor's jobs are being redefined. The doctor is now the head of a team, and that team is delivering healthcare services. And so the team of nurses, nurse practitioners, physician assistants, social workers, psychologists, that whole team, plus the back office part of it, all of that is being changed. You may not know this yet. It is sweeping through the United States, but it's all because so much of that work that used to be done is now being done by computers, and that frees up people to deliver more personal service to the patients that are coming in. That's I think a great thing. It's long overdue. It was always the promise of digitization. I think it's come much more slowly than people predicted 10, 15 years ago, but it is starting to happen now. I see it very much. And so as we reorganize, and I'll just shout out a few, there's a few companies, if you want to look at their websites, that do this. Iora Health, Firefly, there's dozens of others, where it's not your parents' doctor, and the receptionist and the back office person. It's really, the whole thing is getting reoriented. In that process, there is this new role, which is who is the person in that office who is designated as the person who is helping with the social determinants of health. And sorry for that long answer, but just in the context, a lot of things are changing. This is one piece of that changes. I think it's a terrifically positive change because it's something that we struggled with, frankly, before, and now is actually explicit. And it was made explicit because the change in the payment rules really is what originally drove what is now, I think, a very positive response to changes in payment rules.
See another question there?
Yeah, hi, my name's Rob Schreiber. I'm a geriatrician working with a PACE program called Summit Elder Care that's part of Fallon Health Plan. Hi, Tim. So my question to you is this, and Connie, I'd like your take too. I get the new role, and I think that's really critical in PACE for people. I think most people know what PACE is. We're doing this. But prior, what we found is when I had worked with a organization, an ACO, in a medical practice, that need for social determinants, providers just don't know that. Has there been thought, because I think in this audience there are probably people doing this where there's an embedded social worker from a AAA who knows the network, paid for by the organization, And is that, have you thought of that? I have used that, and it was a godsend for the providers and for the organization. Not only did they identify the acute issue that the provider did, but they did a comprehensive review and found many other issues. And so my question to you is, does that make sense? And would that work? Could that be a sudden change that could be literally done tomorrow?
Well, from my perspective, it is. And I should have said that, if it wasn't for the PACE programs started in the early 80s, it was actually that sort of invented this, but never scaled, right? That was the big problem, because dozens of papers have been written about the success of PACE programs to actually provide wraparound services to patients, and yet they didn't scale. And so what I see in some ways, the ACO is the scaling of the model that was developed, of the practice model that was developed in PACE programs. And I'm not, I wouldn't get, I'll take whatever payment mechanism stimulates this kind of change. I wouldn't be an ideologue about the mechanism. I would say PACE, great model. ACO, it also works. So I think your description of the mechanism to provide the solution makes a lot of sense to me.
Can I just also add, I think this is an opportunity for payers to align, because I'm thinking specifically if you have 5, 6, 12, 15 payers and they all want to have their own person, forget about it. It ain't going to happen. But is there a way to come to some commonality where that staffing is built in and the payers are kind of sharing, I get 1/10, 1/10, 1/10, 1/10, but there's got to be some agreement there, and I think that can be leadership from the plan level, but it also can be either from the state or federal. How do you incent that type of collaboration? I think we're seeing it in some other areas, particularly thinking about there's a panel this afternoon. I would suggest you take a look at it with one of my colleagues about this, but where we're doing some stuff in housing projects where it's not just United members. There's a lot of different members. How do we start to figure, let's realize that cooperation, not competition in this space, actually can help to get people engaged with the system. So I think that's another opportunity too.
And can I just express just really quickly a bias? And my bias is that I would prefer to have one person in my office available to all the different payers rather than go to each different payer for each different person. Like, I prefer not to even know who the payer is for my patient. I want to provide them services that they need regardless of payer. And so I have a bias, which is, and I don't need to be supervising this person, but it is much easier for me much more efficient for me to get services for my patients if the person coordinating that is local to me and one person, not lots of different people. It's a logistic problem.
So to build on this point for a sec, one of the things for those of you who come from the healthcare sector, this is a really important sort of future state discussion we're having here, because what it also requires, you can echo this if you'd like, but I want to go ahead and say this first. What this requires of plans and providers at bear risk is the willingness and ability to cede a certain level of authority around decision-making to that individual to make these things work, right? So it's a different kind of model, and I think the idea that I'm with you, Tim, like in a practice environment, I really want to treat all my high needs, at-risk individuals equally, more or less. I mean, I get that there's going to be some differences around the edges, but I want to know that that person in my office, in my practice, in my plan, has the authority, within some range, because all of us have our pay grade and there's sort of the limits in what we get to do all by ourselves, but that they're actually authorized to make a difference in people's lives, right? It's not a data recording exercise, but it's an action-oriented exercise about improving outcomes. So to me, this last set of, it was a great question, and this last set of discussions about future state is key. Connie, anything you want to add? And then I want to take one more question before I bring us to a close.
You hit on some logistical kinds of issues that, since I'm kind of speaking for the field in terms of the aging.
No pressure.
No pressure. One of the dilemmas that we have had as we've moved in this arena is that as different payers have wanted to contract with us for work by our social workers or our community health workers in the field, we don't always get enough volume that we can have a dedicated worker to that payer, so to speak. So we have had to find ways to be able to adjust our field operations with the use of technology so that when I send somebody, one of my social workers, into the field in the morning, her first client may be paid for by Older Americans Act. Her second one may be paid for by Anthem. Her third one may be a med-waiver patient. The fourth one may be United. So we've had to construct a technology platform that allows for a service delivery segregation, but a service delivery protocol. So if there are differences from payer to payer in terms of what they want, in the field, I can give that to them. We can segment their data so it's protected, because that's also a huge issue when you have competitive groups that are paying. So we've had to find a way to segment that data, but then I want the ability to pull that data back together so that I can continue to refine the work that I'm doing and make it better. And I think that's one of our challenges. And if there's a panel that's dealing with that today, bully for them, because we've come a long way, but I think there's still ways to go. The other part, I just want to get back to a little bit of what Dr. Schreiber said about PACE, because I think PACE, we're starting to PACE in Northeast Indiana. In fact, my health system partner, Greg Johnson, who's their chief integration officer, is here today. And he and I have absolutely figured out that if you join forces between our network and sort of that CMS one blessed, maybe that's the wrong way to put it, but it's kind of their blessed model of integrated health. That's the one that I can take a lead in and he can take a lead in, and we can make this thing come together specifically for those very vulnerable duals, those patients that have these multiple needs. That's now informing, I just wanted to say, that's informing a lot of the work that I'm doing with the rest of my area agency on aging. Because we're now, as we step back and we started looking at, okay, for people who aren't PACE members, but they have a serious illness, how do we help them build that integrated team within, their medical community and their social services? There's a lot for us to be learned, even if PACE doesn't scale widely, but I think it's going to actually grow a whole bunch. But I think there's ways that we can pull PACE-like things into the network and be working with healthcare and actually see some of the same benefits attributed to those individuals.
I think you're totally right. I see a question back there. Yes, please.
Good morning. Thank you, panel. You've done a great job. My name is Sharon Williams. I'm the CEO of Williams Jackson Consulting and do work with the National Aging Networks who are represented here. My question is, I feel like a mosquito in a nudist camp. I know what I want. I just don't know where to start. It's really... Okay. My background is both in healthcare and on the CBO side, so I understand the perspectives of both sides of the fence. One of the challenges for us is that as the CBOs are working with the high-risk, chronically ill population, more and more of that group are being moved into Medicaid managed care programs across the country. More and more of them are leaving fee-for-service. More and more duals, 13 million duals, 15 million duals as of 2020. The challenge is that the health plans, United, Humana, all of them, are in a state working with the Medicaid agency 2 years before the state plan amendment, 2 years before the RFP is even produced. The CBOs, unfortunately, don't know that Medicaid managed care waivers are even going on until somebody shows up and says, I need you to sign this business associate agreement and do a contract because there have been some changes in Medicaid. It creates an uneven playing field, and one of the concerns plans have all the time is states are putting more mandates about community-based services, but the networks aren't ready. and the networks aren't ready because they didn't get the 2, 3, 4-year head start that the health plans have. So what are your suggestions to address issues like the education about how Medicaid managed care waivers happen? Because those populations that these community-based organizations have been serving in fee-for-service are starting to dwindle, and they're moving into special needs plans, into Medicaid MLTSS, and the only way these CBOs can continue to serve them is through contracts with these organizations.
I'm guessing that was kind of directed at me. So I would even amend your comment that I've been witness to an example of not only 2-3 years before, but actually after things have gone live, where I'm sitting in a room and asking a question. I'm like, are you guys going to respond to this RFI? And the response was, what RFI? And I said, well, this. And they're like, oh, that's not about us. And I said, well, here's a paragraph. The last time I checked, you provide these services. Shouldn't you respond? And there was this, oh, crap look in her eye. And then I gave a lot of homework to the CFO that day because he had to respond in about 24 hours. At a real basic, and this is not by any stretch of the imagination flippant. I think a lot of it is thinking about state partners. In my old role as a Medicaid director, if you were to walk in my door and say that I'm with so-and-so, let's say that you were with a housing agency, and I joke with one of my colleagues, like, I didn't speak Hauser. I didn't understand it. And it wasn't the fact that I didn't care about it. It was just I didn't understand what low-income, I didn't understand what low-income assistance was. I didn't understand, like, what do you mean you're talking about development? I need to be able to get people into housing. Part of it is just get the number, call, and make sure that you're educating not only the program, but the supporting staff that are around him or her. I think that sometimes gets missed. Actually, not sometimes. It does get missed a lot. I also think it's a call, though, to the health sector, though, that we're moving at a much different pace than the CBO sector. And I see this not in almost every state that I go into. I ask a question. I've been told I'm not supposed to ask it, and I'm not going to ask it here. But rhetorically, how many people represent, outside of AAAs, how many people represent CBOs? And, okay.
Rhetorically.
Rhetorically, because I didn't ask the question. How many people represent the healthcare sector? Rhetorically. Yeah. Now I'm asking for real. Yeah. You go into any specific room, and it's dramatically the other way. So we're really good in the health sector about talking about this. It's part of the reason why I'm on the speaking circuit, though, I think. We've recognized that we need to figure out how to speak CBO better. We need to understand what that means from a health plan perspective. Do we need people in the health plan that actually go out and talk to CBOs, understand what they do, educate not only on what the CBOs are, but understanding what do the waivers look like? What does it mean to me? Am I part of this? There are people in Medicaid that don't understand what waivers are. So it's really difficult to understand what that means if I'm a CBO that's trying to actually provide services day in and day out, and I don't understand it. So I think that's one of the fundamental things we can do. I also think that at a national level, you're seeing CMS take a bigger role in this. You see National Association of State Budget Directors understanding, wait a minute, maybe I need to understand more about what is this stuff. And then NAMD is the Medicaid directors. It's something that is, it's not as important when you're trying to get your waivers through or you're trying to balance your state budget. You just got to be there and you got to educate those folks. But I agree with you. It's something that we're moving in healthcare a lot faster than the CBO space. And as we're seeing in some of the CMMI grants, we're really good at referring. We're really good at screening. We make that handoff, and the CBO is sitting there going, I don't have any more capacity. I don't have any more money. I want to do it, but I can't. That's where I think we have to be very cautious, because the resiliency in the CBO sector is not as resilient as it is in the healthcare sector. If we start to erode that sector, it's going to be hard to rebuild. So let's not break it.
One of the things that could happen if we're not careful is an unintended consequence of us weakening the community-based organizations rather than strengthening them. Mm-hmm. So we have to be really cognizant of that. And one of the things I'll say, Kevin, is when people ask me which sector I represent, I now raise my hand for healthcare as well as social services,
right answer.
Because I am part of your continuum.
Yep.
I know I am part of your continuum. So I'm starting to identify myself that way. I would say we have a challenge in our network that is you've just touched on, which is trying to lift up this network as best we can, as fast we can, with some limited resources to do it. But it's not an impossible thing to do, and that is witnessed today as you hear. I'm looking at June Simmons, and I'm looking at Kathy Vesley, and as you hear these people who have actually been out there building these state networks talk, we've done it with one hand tied behind our back and, a little string, a little wire, and we've made it happen. If you actually resourced us to do this, you would be amazed at what we could deliver for you. And I think that's the part that we have to, keep in mind, because you don't want us to go away. You want us to be strengthened. And we want to be strengthened, because in the end, it will be that individual in the home with all of those social determinants of health issues, which, by the way, they call their lives.
Yep.
That will benefit if we can get that message done today and the action steps we need done today.
I think we've had a wonderful panel discussion. Want to thank my panelists. They're going to be around today, so please continue the discussion. The point was to be honest and provocative with a clear viewpoint. I hope it sets us up for what happens over the course of the rest of the day. And we look forward to hearing back from all of you at the very end of the day. So with that, let's take a break, and then we'll pick all back up here in this room.